I was so lucky and happy to be involved, and she asked me to kind of manage some of this work and develop this tool. So this is, I guess, year two, or almost 2.5 years that we've started, and it's so good to see how it's really happening on the ground and the voices are using our tools. So what I'm presenting on is not actually a tool. We are calling it a matrix because, as you guys can understand, a matrix is something where a few separate things can originate from. Because if it was one tool, you would say, okay, I've developed a tool that really measure HIV or maternal health, and then tomorrow someone will want to come and measure their abilities, and so it won't be complete. But the methodology as we are presenting here really applies to anyone who wants to come and add, let's say, depression as another specific diagnosis. So calling it a matrix, that will encompass so many tools moving forward, as long as the flow and the methodology and the thinking behind it keeps consistent with the delivery and always measuring how far we are coming and compared to the actual achievements. So this slide, I'm stealing it from Joya. She used it. And really what I want to highlight here is what Joya mentioned before. They saw a huge increase in utilization here. And then the question was, as she was saying, a lot more. And the question becomes, is this universal? Can we be happy and celebrate? Maybe or maybe not. It's a yes or no until we measure, and that's where the tool comes in. So one of the things we wanted to say was really mapping the burden of disease in places where PIH work, and hopefully once we know how to do that better, kind of help others also use our approach. So we've so far started measuring around the key priority clinical areas, which most of them feed into the primary care. And so, you know, many people have started this, they launched the Global Burden of Disease project. And right now there's a good institute that's doing it with Chris Murray at the Institute of Health Metrics in Seattle. So we are using some of their resources so far to look at how does this look like, but also translating what they see in terms of values and qualities into the actual number of patients, what that makes sense to us. Also, we used some of the demographics and the surveys and things that we find in our countries to tell us really what's happening in our catchment population, because if you find the prevalence rate of acute malnutrition in Malawi, the DHS there will tell you something different from what the DHS will tell you in Liberia. So we are trying to use the official national sources, but specific to the countries, to also look at how the burden of these diseases and they look like. The key thing for our tool and our metrics we are developing is really the catchment population. So PIH is working in public facilities, and same thing with the Pivot and other people. So what we know is the governments usually try to estimate the number of people who live in the catchment. As that's not very accurate, but it's one of the best way we can estimate who are we responsible for and how many people out there are going to be demanding services from us. So I will show you as I continue to go. We try to keep this as open as possible. If the ministry tells you 500,000 people as a catchment, we add another column that says additional population. One example is one of the districts in Rwanda, Kirehe, where one of our district hospital is in charge of 300,000, but over the last 2 years, there have been refugees who came from Burundi, almost 100,000. So we have to add those. We don't know when they will move out, but they are seeking care in that catchment. So we always keep that, and it also plugs into the methodology of this one. So just to mention the goals of these metrics. So we developed these tools and really to, as Joel mentioned, try to benchmark our resources against the burden of disease. Some people will be like, okay, if you try to benchmark your resources, you will be overstocking. supplies, there's no way all of the expected number of pregnant women are using the crude birth rate. There is no way all of them will come and seek care at the facility. So if you try to get prepared for all of them, nurses, midwives, delivery packs, you will be overstocking. So as you say, we probably won't have even resources to stock for all of them at the same time, but at least having that idea of how many we should be prepared for, that's one huge step than just operating blindly. So we are trying to open that black box that has been there in the delivery systems for so long. And now, I liked when Rob was presenting, it sounds like easier once you have the politicians buy into this UHC, they can run their campaign behind it. But sometimes having someone and say, okay, actually, but the black box over there in terms of delivering this is how big this is. It's easier to say yes, but also let's think of that 5% or 1%. This will open this box, and then you can see if that will fit into what we are looking at in terms of systems, staff, and supplies. So the other key one I'm highlighting here, we'll be looking at the tool that compares the actual data, which is the achievement, and we compare that to the coverage under UHC, and then we can be able to see the gap. And at some point in the future, we're actually thinking that we can kind of quantify that gap in terms of money and resources, cost out in each places where we're operating, kind of have an idea for fundraising purposes, how much would it take to cover this gap in terms of coverage. One thing again to mention here, the coverage right now we are measuring with our tool, it's what in the literature they describe as a crude coverage. It's not really the effective coverage that takes into account the quality of care. So we are still under the huge assumption that the quality of care we are covering, we are providing in our PIH facilities is good, but we know we are not there yet. That's why people like Margaret and Manzi and other people want to really partner with you so that once we measure the actual and compare to the coverage under universal health coverage, we should be talking about the effective coverage, good quality of care, without just assuming that that's what we are doing. So the history, Joy mentioned this earlier under the positive synergies and the other slides. So once they started to see the jumps in terms of the people coming now, utilization going high, but that question remains of, is this it or there's still a lot more? So they developed what initially was called MOXAT. I actually used this name for a long time until we named it to PIH-UHC metrics. So this version was called MOXAT, Mukherjee and Sati, Dr. Sati. So it's Sati, Dr. Mukherjee and Dr. Sati in Lesotho. That's when they were thinking more about patents, so that maybe no one steals you. So
I couldn't convince anyone to use it.
I actually loved this name because it's so creative. But so the earlier version of MOXAT, as beautiful as it is, it was kind of not easy to transmit and send it to someone and say run with it. But all of the concepts we are using today were there. It's just like we took some of that and we put it into Excel and formatted some of the rows. And also what we did in terms of improving MOXAT was, for example, looking at each clinical area, like HIV. We wanted to see what's the world currently interested in as a complete package of care and what should we measure in terms of HIV. Three main things, 90, 90, 90. So making sure our tool is capturing 90% of people with HIV know their status, 90% of those who are positive start their treatment, and 90% of those on the treatment have their viral load suppressed. So making sure really if we are measuring and developing a tool, it has those three components. We did the same thing in maternal health, what's being measured these days, so to make sure what the former MOXAT didn't have, we are expanding it to include this. We also started to do the NCDs and other tools. So you can see that, as I say, you get the expected, and then they had some of the numbers before, and then you can see the percentage in coverage, and yeah, so these are the changes in terms of this. So I will not go into the specific in each of these roles. This was an example of and the history of the tool, but when I go to present some of this, I will show you the methodology of how we are developing this. So the second version of the tool we came up with between October 2015 and January 2016, we did a mapping. It was a kind of the pilot mapping in each of the countries. Actually, that's when we tried to involve Pivot in Madagascar. And we took each facility, one facility in each of the countries we worked in. So we developed the tool that focuses on key priority areas around the primary health care, HIV, women's health, child health, which also include malnutrition and underfile. And then we did the mapping to ask people at the facilities in here to give us the actuals. Actuals meaning once we have the projected number of INC using the recommended before visit, then we will be asking them to give us how many visits are happening so that we can really test and pressure test our tool, see how it's working. So the earlier version of the tool looked like this. It was a success, and we started then to continue and develop it. Again, I will go into what section, what goes into this tool over the next few slides. So this is the current version that we're working on right now. Back to this slide, you guys can see that in this type of Excel, you have to click on one tab. Let's say you want to look at coverage for HIV, and then there was a lot of scrolling up and down, hiding some of the rows. For example, family planning is hidden. So if this is capturing what it has to capture, but there was a lot of scrolling back and forth, and it's not as easy when you share this and with someone who doesn't have time to scroll and make sense of what's happening here. So we said, okay, what if we make this more user-friendly tool, and someone can really put in the information. They are busy, they are providers, they are district managers somewhere in Malawi. All they need to plug in is a few things. Say, what's the number of the population I'm in charge of? What's the burden of the prevalence rate of the service I'm interested in? And then they can easily see what they are leading up against for that year. So we said, okay, instead of this, let's make another version. I've been working with Adash and a few other people on the team. And we are collaborating with a group of analysts from the analysis group. It's a consulting company here that really one of their managing directors on the board of trustees for PIH. They are providing this volunteer work to help us really reshape this tool in a way that we will be able to share, and even once we know it's working well in our settings, we can share with other people. They can use it to measure their own coverage. So the new tool, the way we are using it right now, so right now this one is still PIH. It's focusing on the key PIH countries for this, you select, I call it a disease or clinical area you are interested in. So we're still adding more. And within any cities, there are so many things underneath. There are hypertension, there is diabetes, there are so many other things. So for PIH, we will try to build something we feel like it's covering almost 95% of our primary health care we provide. But again, why I call it a matrix is that it will never be complete. If someone wants to add something within that 5% missing, this gives you a pathway of how to do it. And it won't be something that you will have to come to PIH to do it once we start sharing this externally. So again, it's very automated. You select the country, building our catchment population, all of the facilities, all of the districts we work in. We choose the disease. Every year we'll be updating, if it's HIV, we'll be updating the incidence and the prevalence rates using the surveys, the national surveys I mentioned, the demographic and health surveys. And yeah, so the methodology then, if I drill it down, what we do, the key one is the demographic and epidemiology that we start in and make sure we have those inputs. The catchment population, you add the additional population like the refugees and mobile populations that won't be there permanently. So we try to talk to people, our clinical person and managers on the ground. And if you are doing this outside of PIH, you have to go through the same thing. So then look at what key clinical areas you are looking at, know their prevalence rates, incidence, and so some of them will use the point prevalence. There are some others that we feel like they have like an illness of short duration, like malnutrition. If you use the point prevalence, you might be undercounting. So in that case, we are using, it's a kind of a prevalence that takes into account the timing, the cumulative incidence. So we are still involving some of the good epidemiologists in our network to make sure we are getting things right. But the overall goal is to have these inputs that they will help us later on in the formulas to come up with the burden of diseases. For maternal health, we really rely on the crude birth rate. And for outpatients, we are using the service utilization rate. So this one is a tricky one because if you want to estimate the number of people who will come at your outpatient clinic, you need to know how often the people use care in the year. So there is no good data in some of the low-income countries. There is a lot of data for OECD countries and higher income countries on this. But when it comes to us, it was so challenging to say, okay, if we are aiming to be prepared at the UHC level, optimum inputs and resources, what could be the target utilization rate per person per capita per year? So we used a combination of methods. So we did some literature review to look at countries that tried to do this, like Kenya. So they had around 3 visits per year per person, or 2.8. And for that, Kenya, to some extent, is not comparing well to some of the countries we work in. For example, Sierra Leone, some of the countries are still very behind. Using the number from Kenya will be a little bit higher. So what the other way, we looked at how we can calculate our own optimal utilization rate. So there was a method that was developed at the Rwanda School of Hygiene and Tropical Medicine. So we were able to use some of the formulas. It's actually on the next slide. So this formula here. So looking at our own data, we're able to know, okay, how many new consultations, and if you know our catchment, then the new consultations, and then you multiply by your period, then you are able to come up with. So we got, at PIH, we got something around 1.2 in most of our cases, because we knew with our new visits in our catchment in Haiti and in Rwanda and the other places, but we also know the catchment population, and we were estimating for the year. So these are the number of unit times which are the months. We have 12, and then this is 1 year. So yeah, this is how we came up with the 1.2 you would want to start showing you. But again, this is one of the areas we still have a yellow highlight. We don't know whether 1.2 is good enough, so you can plan your resources around there. Because if you look at this slide here, it shows you what other countries are actually doing. So this, someone might say these countries have a moral hazard because they're overusing it. But again, we would say no. So its average is around 6 visits in these countries, or almost 7 visits a year. So to show you that even when we use the 1.2 for our own PH countries, we see so many visits expected than what we are actually observing. So that too, at the lowest planning possible, at the lowest forecasting possible at 1.2, we are still expecting huge numbers of visits than what we are seeing, which means if we want to build a hospital in Liberia somewhere, this is what now we should be looking at. We should be opening our black box here and say, okay, what's the purpose of this hospital? Which service area this hospital is going to be covering? Even by using that 1.2, you see that you will need bigger than what we have or what we have resources to do. And this is also this is the best way to plug this into the conversation that Rob was talking with the politician today. It's more of like, you're committing to doing this, but really that's people like Partners in Health and other people who have been in delivery for so long time, tell you what they're observing and also compare to what we should be expecting and plan your resources based on this. If we plan our resources based on 1.2, we know we are still not there at the UHC, but we also know that we need to start from somewhere. So we won't be jumping to 6.7. It will go beyond our charts. But let's start at 1.2 and we'll keep increasing and see how things look like. So some of the way this tool looks like once we plug into those numbers. So this is like the front dashboard that a busy manager or someone, I was telling you, somewhere in their office, they only have 5 minutes to see how their services look like. So they plug in, let's say it's a person who is at this clinic in Las Caobas, Haiti. So what they will have to do is, so we hide from them all of the assumptions and the calculations in the back end. All they have to do, they will say, okay, Jean-Claude didn't know my catchment population is using the placeholder of 47, for example. They can change it, put their population they think they have, and if they have refugees, they can add them in here. And then they put their current actuals. This is the simple monitoring. We are collecting this data everywhere, the testing. And most of these few indicators, we tried to be short intentionally of what people see in the front end, but we still have a long list of indicators in the back. But these really capture those 3 key areas I mentioned, the 90-90-90 in terms of testing. People know their status, and the people who are positive are on the treatment. And also you can see those who are treated, how many people have viral load. So, and then our projections under UHC are also following the same. So right now, this example I didn't put in the actual, but if the person sitting in this clinic puts in the actual here, this will update and it will show them the graph. So these are the projections, and the actuals will show up to improvements to this one. They can say, okay, testing wise, I'm doing this and this. And if they need much more to see much more, there is other tabs that they can go to. But this, for each clinical area, HIV, maternal health, malnutrition, all of them, they can just use this dashboard and quickly see what they're up against that year, and they can plan accordingly. In terms of malnutrition, this is how our mock-up model started looking like before we put into that automated tool. I mentioned that some of the illness, depending on the duration of illness, you cannot use the point prevalence for 1 year. If you're trying to estimate the cases for 1 year, malnutrition cases, if you leave them untreated at some point, I don't know if they will live that longer, or some of them will get cured on their own, or some miracles will happen. We don't know what happens. But the method is still the same, catchment population. And then you have to know the proportion of children under 5. So right now we're still doing it for under 5. Sometimes for pediatrics, you can go up to 14. And then you change the formula here. And so once you get the number of children under 5, the prevalence of severe acute malnutrition is published every 5 years in the demographic health surveys. And you put it into that, then you get the expected cases at the beginning of the year. This one is the point prevalence. So you use the point prevalence right here, the one you have. At any given time during the year, if you come and cut from there, you use this prevalence and the catchment population and the population of that age group, it gives you these cases at the beginning of each year. Then, because it's a disease that over the course of the year, some kids will get cured, others will keep coming in. We try to estimate the cumulative incidence so that you can have an exact number or closer to exact number during the year. So the period of estimate then will switch to 12 months, but some of these kids will be there for 7 months, some of them within 4 months they will be cured, some of them. But for some, we are using the duration of 3 months. So yeah, so you can also change this one to 4 months, but the data we had right now, all of the literatures we had, they were pointing around between 3 to 7 months. So we are using this one to come up with that. And then once you adjust this factor over 12 months and your prevalence rate, the new prevalence, which is also called 1 year cumulative incidence, goes to 4.4. And this is the one we are using now to gain all of the cases during the year. So the new cases plus the cases at the beginning of the year gives you the cases you have to deal with, that you have to be prepared during that year. So in the process where we've used this tool, we are comparing the actuals to the enrollment. This is an example in the scopus for HIV in the catchment. And so you can see how over time, based on what has happened with resources and strategies and all of that stuff, using our tool, we can really compare the actuals to the projected. And right now, because of the falling prevalence rates and the other factors, we're actually seeing that some of the facilities in Haiti, in terms of HIV, they have achieved UHC. So in terms of coverage, so it's still crude coverage. It's not, again, it's not, what's the term? I'm trying to forget. Effective coverage in the quality of care. But we think some of the facilities in Haiti are achieving the UHC. This is another example from the maternal mortality reduction program in the hospital. Same thing, the actuals during this year, they are almost catching up to the expected in terms of the women who are delivering at the facilities. Try to show this one. So, to conclude, I want to say that while UHC really is achieving some of the goals, and most people are trying to fundraise and work towards the financing, so we need really a strategy that can help people who are doing the delivery on the ground to understand how much they should be planned for, and if they're raising funds to cover these critical areas. So, and one of those tools is our metrics that will cover different areas, clinical areas, and it can help people really come up with those numbers. And so we are continuing to work with this, and we hope this will strengthen our systems and make UHC over time. Thank you.
Any questions for Jean-Claude?
What other things would be there that would give some idea of where to go? What do I do with this? Told me, I do this, that might be a very interesting
Yeah, yeah, that's true. And actually we thought about that during the mapping we did, because one of the areas when we're trying to estimate the gap in coverage for the under five. So in some of the countries where we're working, for example, in Rwanda, Dan knows, we have community health workers who use, they actually provide the care. They have backpacks with medications and all of that. So in terms of the actual coverage, we took into account those cases that being treated in the community by those backpack holders, and then we added those ones at the facility. So that takes access of the table, and then you can see that the challenges then you are having are not limited to access in that case. But for places where we know a facility is assigning 2 millions or something, like 20 or 100 times over its capacity where they are supposed to be. So yeah, things like a Google map. So sometimes we estimate and we will say, okay, this is the number of, we are projecting that you only have four doctors and you need 25 doctors. You need to have 2 rooms for women who are delivering. You need 26 rooms. In those cases, what we're trying to come up with, we'll be working with our infrastructure teams moving forward. Did you mention this? What does that mean? Does that actually mean another facility here and there instead of expanding rooms in the one you are studying? So that's where Google Maps and the things like that you're saying will help us. But yes, I agree with you.
Yeah, no, I think that's great. We synergies was a mixed benefits. That we can other programs but I think we kind of looked I think one of the that we so we're within 2 hours of the health center because the country's so that we don't really need the how you other systems will be really interesting to do more of that.
Yeah. Yeah, so that's a good question. So what we did initially was, so we are providing, back to what Richard was saying, the qualitative. So once we send this tool out, we have at the end a role for assumptions and some guidance we give to people. So we've been mainly focusing on the added population because all we see mostly in the case of Liberia, we actually see cross-border crossing people coming from Cote d'Ivoire to get care. So we haven't seen, yeah, so yeah, we haven't seen much of people. It's a good point, people going out, so that we had to actually reduce the catchment. But I think that's a very interesting and thing to keep in mind. Yeah.
people in Uganda say Ugandans why use our services because they're free. And then I'd go to Rwanda and people say, all these people come from Uganda because
Yeah.
our services are better quality.
Yeah.
And you just wonder what the
Yeah.
reality is.
Yeah. That's a good thing. We should think about how to plug into that. So if I'm getting this correctly, so I don't think we've started to go national yet.
Well, unless it's
Yeah, in Lesotho we did that, but maybe Joy, if you want to go.
yeah,
Yeah.
Emily was going to head, if you take her back, is I think the big problem is what's up. Opt out.
So yeah, and another example we have is for Malawi, what Emily is going to present, luckily if we get her. So the methodology, the way we did it, they actually took it in Malawi, went together and sat together with the ministry officers at the district level. So they started with one district and now they are in one zone with 7 districts. So they actually changed the way this tool was laid out to make it more adaptable to the local users at the facilities in Malawi. So the methodology was easy and the flow was as easy enough so that they were even able to change it in a way that lays out what they need locally at all of the facilities. And what she was going to present was the experience on the ground on how they have been using these tools and how the government people now at the district level and the zone level with all of those 7 districts are using this to actually measure their performance against the UHC target instead of some of the blindly set target that were not based on the coverage, on the coverage.
Go ahead, Lindsay. Try to set up
Yes, ma'am.